Welcome to our video on Candidiasis. Let's get started. So in this lecture, we will address definition, clinical features, diagnosis, and management of Candidiasis. Now, Candidiasis is defined as a group of fungal infections caused by Candida. And the most common pathogen, specifically, as far as species are concerned, is Candida albicans. Now, this is a dimorphic fungus, and it forms budding yeasts with pseudohyphae at 37 degrees Celsius. And it forms germ tubes at 20 degrees Celsius. And Candida infections can be local, or it can be widely disseminated throughout the body. So what does it look like? Well, let's discuss local mucocutaneous candidiasis, as well as the invasive form. So local mucocutaneous candidiasis includes several infections. So that can be oropharyngeal candidiasis, Candida esophagitis, or Candida vulvovaginitis. And then, of course, strictly cutaneous candidiasis, or intertrigo. So let's dive into these specific local forms a little bit more, starting with the oropharyngeal type. So the lesions in oropharyngeal candidiasis are typically painless, but the patient can complain of a cottony feeling in the mouth. On physical exam, white scrapable plaques are seen on the tongue, the hard palate, the buccal mucosa, or the oropharynx. And this infection is most often associated with wearing dentures or use of inhaled corticosteroids in patients with a competent immune system. And naturally, if this can happen with inhaled corticosteroids in people who are healthy, then you can be thinking about immunocompromised people as well, especially those with HIV. Now here's an image of a patient with oropharyngeal candidiasis. You can see those white plaques on the tongue. Now the second type of local mucocutaneous candidiasis is Candida esophagitis. This infection is most commonly seen in HIV-infected patients with CD4 counts less than 100. In fact, Candida esophagitis is considered an AIDS-defining illness. So if you've got HIV and you develop Candida esophagitis, then you're considered to have AIDS at this point. Now this is in contrast with oropharyngeal candidiasis, which can be encountered in HIV-infected patients, but it's not AIDS-defining. So that's interesting. So here we're talking about esophagitis as AIDS-defining, but in the same HIV patient with oropharyngeal candidiasis, it doesn't mean they have AIDS. Because again, oropharyngeal candidiasis can happen in immunocompetent patients. So what's the main complaint of Candida esophagitis? Well, that's odynophagia and dysphagia. So in other words, difficulty swallowing and pain with swallowing. Now on physical exam, concurrent oral thrush can be seen. So you can see those white plaque-like lesions, and those are detected when you actually perform endoscopy. That's how you know it's in the esophagus specifically. So here's an endoscopic image of a patient with Candida esophagitis. And note those white plaque-like lesions. Let's move on to Candida vulvovaginitis. Now the most common symptom for this is vulvar pruritus. Also there's dysuria and dyspareunia. And on physical exam, you can see a white cottage cheese-like vaginal discharge, as well as vulvar erythema. And in these patients, vaginal pH is normal. Typically, this infection is associated with an increase in estrogen levels, such as during a period of pregnancy or if the patient is taking oral contraceptives. We actually go into more detail in this disease in a different lecture in which we compare this to other vaginal pathologies and infections such as bacterial vaginosis. Now here's an image of a patient with Candida vulvovaginitis. And you can see that cottage cheese-like vaginal discharge, and you can kind of see why it's described that way. Now the last type of local mucocutaneous candidiasis that we're going to discuss is the cutaneous or intertrigo. Now, the patient typically complains of a sense of burning or tenderness or pruritus, and then even malodor within the skin folds, for example, the axillary area or the inframammary area. On physical examination, erythematous satellite lesions are seen. And this infection is usually associated with immobility, obesity, hyperhidrosis, lots of sweating that creates an environment where this can grow, or simply poor hygiene. Note the erythematous satellite lesions in the inframammary areas. These lesions are characteristic of Candida intertrigo. Now let's move on to invasive candidiasis. So this is a systemic Candida infection, and it can be sometimes accompanied with candidemia, so the presence of Candida in the blood, which is fairly intuitive if you think of it as being invasive and spreading everywhere. That would include the blood. Now, invasive candidiasis most commonly affects people who are immunocompromised. For example, those with hematologic malignancies, or people who underwent organ transplantation, or people receiving chemotherapy. There are varying presentations that the patient can have. And those can range from mild fever to a sepsis syndrome. And again, that's all pretty intuitive considering this is in the blood and it's everywhere. So it stands to reason that they're going to have sepsis and look sick. Also, manifestations can include meningitis, endocarditis, and endophthalmitis. So you just picture it spreading everywhere. Brain, meninges, the heart, endocardium, and even the eyes, endophthalmitis. Now we're going to talk about the diagnosis of each of these, going back to the local types. So the diagnosis of local mucocutaneous candidiasis is pretty much clinical. Now, KOH preparation of specimens and direct microscopic examination can also be performed. And you can also consider specimens. And when it comes to Candida esophagitis, endoscopy with obtaining a biopsy from those lesions, you actually need to do that. So basically remember that if Candida is localized to mucous membranes or the skin, then you can do it clinically. You can consider a KOH prep or culture, and then in the case of esophagitis, get a biopsy. Now, in invasive candidiasis, you need positive blood cultures. And that makes sense because, again, it's spreading throughout the blood, and you're expecting candidemia. So get a culture of that. And you can also consider a tissue biopsy and getting a culture. Here's a microscopic slide that shows Candida. Note those pseudohyphae. You can also see yeasts. Here's another slide showing Candida. And here we actually call it a germ tube. And remember that germ tubes form at 20 degrees Celsius, whereas those pseudohyphae that we showed before are formed at 37 degrees Celsius. Okay, now how do we manage this, starting with the local mucocutaneous type? Well, for oropharyngeal candidiasis, you can use topical azoles such as clotrimazole, and oral fluconazole can be used in moderate to severe infection. However, be aware that oral azoles are teratogenic and should not be used for pregnant patients. Now, in the case of Candida vulvovaginitis, you're going to use oral fluconazole. However, if that patient is pregnant, again, you're going to worry about teratogenic effects, then you can stay topical and use an imidazole, such as clotrimazole, and you just administer that vaginally. And for Candida esophagitis, you're going to use oral fluconazole. Then once again, if they're pregnant, you want to use amphotericin B. So the idea here is that you're going to start low, basically go for clotrimazole, and then if it's severe, you upgrade to fluconazole. And this is really speaking in general terms for all of these. And then if you can't use fluconazole, then you can either default to topical clotrimazole. That would be in the case of vulvovaginal. But in the case of esophageal, that's really not going to cut it. So you're going to have to default to amphotericin B. And then if it's strictly cutaneous, then you can just use something simple, go down to that lower grade like clotrimazole. Okay, now how do you manage invasive candidiasis? Well, here you're going to use an echinocandin, such as caspofungin, and then you're going to remove a central venous catheter, assuming it's in place, because you got to think of what introduced this candidiasis into the patient. And a lot of times it's a tube or a line. So consider removing any of the lines that are present in the patient and treating them, of course, and you can give them a new clean one. Okay, let's end with a quick question. A 40-year-old male presents to the office complaining of pain with swallowing. He was diagnosed with HIV 2 years ago. Physical examination reveals oral thrush. What is the best next step of management? Okay, so here we have an HIV-infected patient that complains of odonophagia. This makes us think of several probable diseases, including Candida esophagitis, or even CMV esophagitis, or HSV esophagitis. Now at this point, you really don't know what's going on. You just know that he's an immunocompromised patient and they've got odonophagia. So you're worried about the esophagus and potentially an AIDS-defining illness. So what you want to do is visualize the esophagus with endoscopy. And oftentimes with that, you're going to do a biopsy. But even before endoscopy, the physical exam of oral thrush makes us think of those different pathologies or infections that could be causing this esophagitis. It's probably Candida. So you actually do skip endoscopy and you can just put the patient on empiric oral fluconazole. And you couldn't do that if you didn't have that oral flush because that's not enough evidence. So oral fluconazole, doing that empirically. But what happens if the symptoms continue? Well, then at that point, you're not so sure about your correct diagnosis. So then you're going to want to go back and get an endoscopy and get a biopsy. And that concludes this lecture.